Welcome to the next in the series of Natera webinars, incorporating a personalized tumor-informed ctDNA monitoring assay in clinical practices for GI cancers. My name is Bob Hansen and I'm today's moderator. Some housekeeping notes. Today's webinar is being recorded. You can ask questions at any time during the presentation by typing in the questions panel in the interface and clicking submit. Our speakers today are first up in terms of the order of introduction, Dr. George Azzi. Dr. Azzi is co-director of the Department of Hematology and Oncology at Holy Cross Hospital in Fort Lauderdale, Florida. He'll be our second speaker and also joining us for the Q&A session. Our first speaker today will be Dr. Angel Rodriguez. Dr. Rodriguez is a board-certified medical oncologist who specializes in breast medical oncology and has conducted clinical research with circulating tumor DNA. He is currently the medical director at Natera, and at this time I'd like to turn it over to him. Go ahead, Dr. Rodriguez.
Thank you, Bob. It's an honor to co-host today's webinar with Dr. Azzi. So for today's first half of the webinar, I'm going to give an overview of Signatera, followed by a review of ASCO 2020 virtual meeting presentations, and which include a real-world study of Signatera, a expansion of our validation study where MRD was evaluated in risk-stratified patients with early-stage colorectal cancer, as well as exploratory analysis, ctDNA analysis and immunotherapy in patients treated with HCC. First, for those who are not familiar with Signatera or Natera, Signatera is a circulating tumor DNA test created by Natera, which is a company that has been a leader in cell-free DNA technology for many years. We have now performed over 2 million clinical cell-free DNA tests worldwide. Natera has offerings in both reproductive health with Panorama, a test for non-invasive prenatal testing to detect fetal-derived ctDNA, and in organ transplant health with Prospera, a test to identify early kidney transplant rejection by detecting donor-derived ctDNA, and now in oncology we offer Signatera. All three of these tests leverage the same core technology, combining unique methods of multiplex PCR along with our proprietary bioinformatics model for detection of the ctDNA signal in the blood. That technology is described in patents and peer-reviewed publications in top journals. It's important to note that there is a spectrum in the use of ctDNA testing in oncology. On the left side is the potential to screen asymptomatic, healthy, and unaffected individuals with the goal of early detection of cancers. And on the right side is the current use of ctDNA in the metastatic setting, where typically the tumor burden and concentrations of ctDNA is high. This is what is typically referred to as liquid biopsy, which the goal is to detect mutations that have been linked to a therapy benefit or treatment resistance. ctDNA is particularly helpful in this setting, especially when there is little to no tumor available. Now, shifting to the middle of the slide, identification and measurement of molecular residual disease is where Signatera's strength lies and where we have focused our clinical research. Presence of MRD by Signatera can identify patients that are destined to relapse. You can think of it as a way to monitor our patient with solid tumors the way we've been monitoring our patients with leukemias for decades, such as BCR-ABL in CML. Signatera can also be used as a surveillance tool for early molecular recurrence monitoring longitudinally. Serial testing can identify recurrences earlier than our current standard of care surveillance tools, such as CT scans or biochemical tumor markers. Identifications of patients with molecular recurrence can allow us to manage these patients with an intensive imaging surveillance program that which could lead to detection of local, regional, or oligometastatic disease that, when treated, can lead to prolonged survival and potentially a second chance of cure. MRD recurrence could also offer a window of opportunity where patients who are asymptomatic and are destined to recur and have no treatment options to prevent recurrence could be directed to participate in clinical trials with MRD as an entry criteria. And finally, the third area we focus on with Signatera is treatment response monitoring and early prediction of benefit. I will show how the dynamic changes of ctDNA and its correlation with treatment benefit can change the landscape of how we design clinical trials and evaluate treatment efficacy. Additionally, ctDNA dynamic changes can complement clinical information and help clarify scenarios where the risk-benefit ratio of treatment is unclear. In order to achieve this unique, personalized, and tumor-informed approach with Signatera, a sample of the patient's tumor tissue is required in the initial setup along with the patient's blood sample. This approach differentiates Signatera from other liquid biopsy tests that have a tumor-naive approach and don't take into account the genomic profile of the patient's tumor. Knowing the patient's tumor-specific mutations allow us to dive deeper in circulating cell-free DNA to find that single molecule of circulating tumor DNA. The first part of the test process involves performing whole exome sequencing on the tumor tissue and match normal DNA from each patient. Based on these results, we can identify the differences and create a molecular signature of tumor mutations that are unique to each patient's cancer. We look at all of the somatic tumor-derived mutations and apply our proprietary algorithm to select the most important or most clonal single nucleotide variants and basically custom design and manufacture for each patient a personalized multiplex PCR assay that is going to target the top 16 clonal mutations found in the tumor. Now, we sometimes get asked why 16 clonal mutations that we vary, and the answer is relatively simple. The more genes that we look for that are related to the cancer, the more likely it is that we can find a tumor. So basically enhance its sensitivity. Now, you don't want to look for too many because you would impact your specificity. So with our current assay, our specificity can be as high as 99.8% when at levels of 0.04% of variant allele frequency. Additionally, it's not just about the number of genes that we select, but also the quality of the genes or the selection of the genes. Oncogenes are more likely to be lost over time to selective treatment pressure, whereas passenger mutations or clonal mutations that are selected in our assay are more likely to persist over time. And notice on the right that we report our results as mean tumor molecules per milliliters as opposed to variant allele frequency, which could be influenced by the level of background cell-free DNA. Signatera's clinical performance has been validated in several tumor types. Shown here are the results of Signatera's prognostic performance in 4 of our publications, including colorectal cancer, breast cancer, our initial validation data in lung cancer and published in Nature, and muscle-invasive bladder cancer. As you see, patients represented in these 4 Kaplan-Meier curves completed a curative intent treatment. And essentially, if patients test Signatera positive with enough follow-up, these patients' cancers almost always recur. And if a patient tests negative and remains negative with serial testing, only very few of those patients' cancer will ever recur. These studies demonstrate that Signatera can identify micrometastatic disease in patients that will experience disease recurrence. And these 4 publications reveal that Signatera can perform better than our traditional high-risk factors that are currently used to predict recurrence. Moving to our the presentations that were shown in virtual meeting ASCO 2020, I'll start with the second one. Circulating tumor DNA to detect minimal residual disease response to adjuvant therapy and to identify patients at high risk of recurrence in patients with stage 1 through 3 colorectal cancer. So the goal of this study was to expand on the previously published colorectal cancer dataset to further validate the use of Signatera ctDNA assay to detect MRD in colorectal cancer patients at high risk of recurrence during and after adjuvant chemotherapy, and to determine the molecular lead time of recurrence between ctDNA detection and radiological imaging. In this study, 198 patients were enrolled, 193 cases were analyzed with a median follow-up of 22 months, ranging from 1.4 to 42 months. Most cases had stage 3 disease as well as stage 2 disease. And patients had baseline Signatera performed 1 month after surgery and every 3 months thereafter. A total of 1,052 plasma samples were collected, and Signatera results were then correlated with outcome. As you can see, Signatera performed exceptionally well in this study. ctDNA positivity postoperatively and longitudinally were associated with worse outcome. On the left, when looking at the results of Signatera as a single time point after surgery and prior to chemotherapy, 14 out of 152 patients had detectable ctDNA, or 9.2% of patients, which again included stage 1 through 3, mostly stage 2 and 3 colorectal cancer. 11 of those 14 patients who tested positive had relapse of their disease. There were 3 patients who did not have a relapse, who were ctDNA positive postoperatively but did not have a relapse, but they did have clearance of ctDNA after adjuvant chemotherapy. In the middle Kaplan-Meier curve, illustrating patients who were tested after completion of adjuvant chemotherapy, a positive resulted in a hazard ratio of 27.9. And post-adjuvant MRD positivity is indicative of treatment-resistant disease and identify patients in need of better than current standard of care treatments. The third Kaplan-Meier curve on the right, which include all patients, including those who did not undergo adjuvant chemotherapy per physician or patient discretion, revealed a hazard ratio of 47.5, so patients who tested positive were 48 times more likely to have a relapse than those who tested negative. These results show that a positive Signatera result is indicative of micrometastatic disease that is destined to relapse. The clinical value of knowing this information will allow you to better assess prognosis prior to recommending chemotherapy, and also enroll these patients in intensive surveillance programs where a multidisciplinary approach will allow you to find a potentially curable oligometastatic recurrence and treat it accordingly with your surgery or radiation oncology colleagues. Alternatively, identification of patients with treatment-resistant disease could help identify patients who are best served with a referral to a clinical trial. In the study, the lead time over radiographic evidence of recurrence of disease was approximately 8.15 months, ranging from 16 days all the way to 16 months. But it is important to note that in this study, because it was a retrospective analysis, the treating clinician did not have access to ctDNA results. So in real life, the molecular lead time may actually be shorter, since having a ctDNA positive test during surveillance may lead you to further imaging to find that recurrence. And then finally, on the right side, a multivariable analysis with traditional risk factors that are currently used in the clinic revealed that longitudinal ctDNA was the only significant risk factor for recurrence of disease. So moving on to our second aspect, which is the number one here, tumor-informed assessment of molecular residual disease and its incorporation into practice for patients with early and advanced stage colorectal cancer, is basically a real-world look at MRD detection rates with Signatera. So ask yourself, what is the MRD detection rate in colorectal cancer patients, and how could this reflect also the expected recurrence rates of within colorectal cancer? So in this study, 535 unique patients with stage 1 through 4 colorectal cancer who underwent ctDNA MRD testing as part of an early adopter program were analyzed. A total of 750 plasma samples were collected. Most of these patients had colon cancer, and 57% of the patients were male. So I first want to show you what the optimal testing time point is for that first blood draw post-operatively. So what this shows is that due to post-surgical trauma, cell-free DNA levels can rise shortly after surgery. And these higher cell-free DNA levels may reduce the detection rate of MRD when tested too early. So the optimal MRD time point for that first blood draw is between 4 to 6 weeks after surgery, ideally approximately 4, so that you have enough time to get results for decision making. And then I'll show you later how in oligometastatic disease also the testing time point, approximately about a month after surgery is the most ideal time point to test. So in terms of correlating with clinical factors, the T4 status was the only significant covariate associated with ctDNA positivity, or basically patients with T4 disease as opposed to T1 through 3 were 3 times more likely to test positive for MRD, which again is consistent with their higher risk of recurrence. Now, in terms of the actual MRD detection rate that was seen, post-surgical ctDNA detection was significantly associated with the stage of disease. 7 out of 68 patients, or 10.3% of patients with stage 2 disease had detection of molecular residual disease, whereas 19 of 71, or 26.7% of patients with stage 3 disease had MRD. Signatera MRD positive rates approximated expected relapse rates within each risk stage of disease. When you further stratify risk within each stage, MRD detection rates in patients with T3 stage 2 disease was 5.6% versus 28.6% in T4 disease. And patients with lower risk stage 3 disease had an MRD rate of 9.3%, and a high risk stage 3 was 39.4%. 5 patients with rectal cancer undergoing neoadjuvant treatment were tested while on treatment, and 4 of them ultimately tested positive. Additionally, notice that unlike other ctDNA tests, we report results as mean tumor molecules per milliliters as opposed to variant allele frequency. Quantity detected range from 1 mean tumor molecule in 10 milliliters of blood all the way to 8,700 mean tumor molecules per 10 milliliters of blood. And also post-surgical levels of ctDNA did not correlate with stage of disease. In the metastatic setting, the Signatera assay was able to detect circulating tumor DNA in all 16 patients with active metastatic disease. In patients where there was documented stable disease or partial response, 9 out of 15 patients had detectable ctDNA levels, suggesting that chemotherapy can further suppress or be measured by the ctDNA dynamic changes, when going from positive to negative. And in the setting where patients had no evidence of disease, MRD was detected in 4 of 12 patients, again, suggesting the potential of identifying patients with oligometastatic disease that are at highest risk of recurrence. Close follow-up with surveillance and monitoring, the trend in ctDNA would be helpful in those MRD positive patients. Now, shifting to an expanded analysis of the oligometastatic cohort, which was presented in just last week in the European Society of Medical Oncology by Dr. Stacy Cohen from University of Washington. 93 patients with oligometastatic disease were analyzed, where 65% of those patients were male. Average age was 58. Most of those patients had liver-only metastasis, whereas others had lung metastasis. Some of those patients had synchronous metastasis, and some of these patients were treated with resection and or chemotherapy. So when tested before surgery for the oligometastatic disease, 9 out of 9 patients tested positive for ctDNA. If tested post-surgically, then half of those patients had detection of MRD. And if it was tested during adjuvant treatment, a third of those patients tested positive. So again, suggesting that each of these interventions could identify patients with different risk of recurrences. And then if tested during the surveillance, 46 of those patients ultimately tested positive. And again, like our other time points, doing the testing approximately 30 days after surgery is the most ideal time for ctDNA detection. So MRD rates across early stage and oligometastatic colorectal cancer reflected expected relapse rates and demonstrated treatment response dynamics in a clinically useful way. Moving over to our third study, which was an exploratory study illustrating the promise of ctDNA in monitoring immunotherapy treatment response in advanced cancer, and specifically in hepatocellular carcinoma. This was presented by Dr. Xu, a professor from the National Taiwan University. So in this study, the investigators sought to explore clinical trials applications of Signatera monitoring in patients with advanced HCC treated with immunotherapy. Longitudinal and personalized detection of ctDNA for monitoring the treatment response to atezolizumab and bevacizumab in patients with G030140 was evaluated. So as you know, Embrave 150 was the first randomized phase 3 study in more than a decade to demonstrate a statistically significant and clinically meaningful improvement in overall survival with atezolizumab and bevacizumab This combination is now a preferred first-line treatment in patients with unresectable HCC who have not received prior systemic therapy. So in this study, the phase 1b part of this study, where 48 patients within arm A were analyzed in this exploratory study with Signatera. 10 patients who had complete responses, 11 with partial responses, 12 with stable disease, and 15 with progression of disease were analyzed in this cohort. And serial plasma samples were collected at baseline, after 1 dose, and after 3 doses of treatment. So a personalized Signatera assay was successfully designed in 98% or 47 of 48 patients. And detection of ctDNA was seen in 96% of patients, 45 of 47 patients, with a median of 70 mean tumor molecules per milliliter, or a median VAF of 1.8%. So shown here, most responders have decreased or non-detectable ctDNA levels by cycle 4, day 1. And ctDNA levels in nearly all non-responders increased post-treatment, or at least remained above detectable levels. Progression-free survival was significantly better in those patients who tested below the median as compared to those patients who tested above the median when looking at either the results of Signatera drawn at the beginning of cycle 2 or cycle 4. So rapid identification of patients who did not benefit from treatment was achieved by higher ctDNA levels after just 1 dose of treatment. And then from as early as cycle 2, day 1, patients with lower ctDNA levels appeared to be associated with a longer progression-free survival and overall survival. Longer PFS and OS were observed in patients whose ctDNA changed from present to absent after treatment, with on the right Kaplan-Meier curve, basically no events occurring in those patients who cleared their ctDNA. So overall, these results illustrate the promise of ctDNA as an emerging biomarker for patients with HCC or other cancers that are being treated with immunotherapy. And finally, I'll just make some points in regards to CHIP mutations, right? Clonal hematopoiesis of indeterminate potential is an age-related phenomenon where somatic mutations accumulate in cells of the bone marrow. And unfortunately, these CHIPs, they are indistinguishable from cell-free DNA of tumor-derived mutations, and therefore they are by far the most common source of false positive in ctDNA analysis. In our analysis, we could see that the most common CHIP gene was DNMT3A, followed by TP53 mutations. We also see that CHIP is present in up to 20% of individuals who are more than 70 years old, and also that CHIP is influenced by the prior treatment, highest in patients who were treated with immunotherapy or chemotherapy versus those who were treated with targeted therapy. So what's important to know is that Signatera assay actually filters CHIP mutations through tumor tissue and germline sequencing, thereby reducing false positive results, and focuses on tumor-specific mutations for each patient. And with that, I will transfer it over to Dr. Azzi for a review of real-world cases.
I'm going to start with our first case here, which is a 64-year-old gentleman with colon adenocarcinoma diagnosed with a T4N1 M0 stage 3B colon cancer. He had a right hemicolectomy November 11, 2019. The pathology demonstrated microsatellite stable, moderately differentiated with negative margins. 1 out of 15 lymph nodes examined was positive. There was no lymphovascular invasion or perineural invasion. When we assessed him in clinic, he was a high-risk stage 3. The plan was to proceed with 6 months of FOLFOX. And our first cell-free DNA Signatera assay, as you can see, was on November 25th, 2019, which is about 2 weeks after the surgery. And again, this illustrates the point that Dr. Rodriguez was explaining to us about the optimal time point to collect the cell-free DNA assay. And as you can see, when we did it on November 25th, about 2 weeks after the surgery, that was negative. And once it was repeated on December 23rd, 2019, which was actually after the first cycle, it was positive, meaning that possibly there was some interference with the normal cell-free DNA background levels in those 2 weeks after surgery, and an optimal time point should be around 4 weeks after surgery. And as you can see in the slides, it illustrates the optimal time point, 2 to 4 weeks. As you can see, the background cell-free DNA concentration overlaid there, and it trends downwards after the first 2 weeks. Therefore, it is really useful to do serial testing. I mean, it might be, from a practical point of view, useful when we see them in clinic to collect that Signatera assay at the 2-week mark, but make sure to get another repeat in about 2 weeks or the 1 month time point to get that assessment of for sure to know if it's positive or negative. And as we can see here, as the patient continued on adjuvant therapy, he had cleared his cell-free DNA, which is a good change. As we had seen from the initial study, the patients that clear their cell-free DNA on adjuvant therapy tend to do better. Obviously, we would want to track him longitudinally, because the longer he keeps in cell-free DNA negative, the lower that risk becomes of recurrence. This patient developed some neuropathy secondary to oxaliplatin, and by the 11th cycle, given that he was negative, both I and the patients felt comfortable to drop that oxaliplatin, knowing that, he had probably already cleared his cell-free DNA and gotten some benefit from the chemo. He completed his chemotherapy on May 22nd. That last time point, as you can see here, is negative. However, it does report higher than average amounts of cell-free DNA in the background. Therefore, given that this is his first time point after chemotherapy, I'm going to repeat that in about a month, just to make sure that that background cell-free DNA, which comes from inflammation or surgery, any type of insult to the body, can increase a spike in the normal cell-free DNA, and that sometimes can mask the MRD detection. Therefore, I would repeat another time point in about a month. We discussed the optimal timing, which should be around a month after surgery is your optimal detection interval. And whenever we get cell-free DNA positive results, that means a high risk of recurrence independently of all the anatomical and pathological correlates, and those patients are high risk. Therefore, in my practice, when I see a positive cell-free DNA, even though in stage 3 low risk, now we have the option of KPOX versus the FOLFOX 6 months, I tend to opt for the FOLFOX 6 months for those patients with cell-free DNA positive, and a bit of a personalization of their treatments. It is important to do that serial testing, especially during the first months. If you get that time point at the 2 weeks to get the test design, make sure to get one right before you start the adjuvant chemotherapy at about 1 month mark, to make sure to determine if it's positive or negative. Obviously, if there is an infection or an inflammation in the body around the time point where you're getting your post-adjuvant therapy time point, make sure to get another one and follow serially these patients after the completion of adjuvant therapy to know if they will unfortunately relapse their cell-free DNA, so we can follow them closely with an imaging regimen and determine if some of them have oligometastatic disease that could be treated curatively. This brings us up to our second case, which is a 57-year-old man also diagnosed with stage 3 colon cancer. Unfortunately, this gentleman had presented in November to an emergency room with abdominal pain, constipation for about 2 days, and he was diagnosed with colon cancer over at the outside hospital, T3 and 2B. No lymphovascular invasion, no perineural invasion. However, he did have 7 out of 8 lymph nodes involved. This was moderately differentiated. The margins were negative. The CT and abdomen and pelvis done over at the outside hospital was read as negative for metastasis. However, unfortunately, he wasn't able to start the chemotherapy at the outside hospital due to insurance issues, and he presented over to Holy Cross in January, which is, significantly delayed. During our first visit here, we collected the Signatera assay. However, the CT scan that was done demonstrated some indeterminate nodules. Out of concern for possible metastasis, I ordered a PET CT scan, and that was physiologic. Therefore, I continued with the planning of his adjuvant therapy with FOLFOX for 6 months. And as you can see, the first time point here is January 28, 2020, and that was at 10.94 mean tumors per molecule. We initiated FOLFOX around February 17, 2020, and we can see by cycle 6 he had cleared his DNA. Again, a positive change, as you can see, that also trending downwards. And here, both I and the patient had access to these results, and the patient initially wasn't very excited about chemotherapy, but once he started seeing that he was positive and this was, trending downwards, this encouraged the patient to continue with his chemotherapy schedule. Also, initially, given that there was some concern about possible metastatic disease, I did collect a next-generation sequencing cell-free DNA panel, which demonstrated positive KRAS and APC mutations. In terms of the future plan, this patient will be completing his 6 months of FOLFOX, will continue the surveillance both in cell-free DNA and repeat imaging, and, putting a very close attention on the cell-free DNA when he completes the chemotherapy, because as we've seen by the studies presented by Dr. Rodriguez, when you're on therapy, that cell-free DNA might be suppressed. So once you complete the therapy, that cell-free DNA will have a better value for the overall prognosis to know about the efficacy of that adjuvant therapy long-term for the patients. And as Dr. Rodriguez presented, we can see that the positivity of MRD is obviously the highest in the high-risk disease. Also, the T4 correlates the highest with having positive MRD. And the mean tumor molecule range here for our patient was about 10.9 at his first draw, and it ranges anywhere from 0.13 to 872. So he's above the median, which is 1.23, but still much lower than other patients in that cohort. So therefore, again, these adjuvant treatment options for stage 3, low risk and high risk. High risk, we usually stick with the 6 months of FOLFOX, but for low risk, we have the option of doing the CAPOX for 3 months versus the 6 months of FOLFOX, and I use the Signatera cell-free DNA assay to determine the extremely high-risk patients, even though pathologically they would be classified under low risk, to determine if I will opt into the 6 months of FOLFOX, and that is very helpful. And we saw the prognostication role both initially post-surgery and also in terms of clearing the cell-free DNA during the adjuvant therapy about the efficacy of adjuvant. The indeterminate nodules that appeared here, obviously there was a significant concern given that the cell-free DNA is positive, and we will monitor this patient closely after he finishes adjuvant to determine the significance of these nodules, as he is high risk for relapse. And obviously a close monitoring would allow us to personalize an imaging program to detect any oligometastatic disease that might be still treatable in a curable or semi-curable fashion. And the clearance rates correlate with response to adjuvant therapy. any questions, I think our panelist or organizer will take over at this point to relay your questions. Please put them in your chat box.
Hey, thank you very much, Dr. Azzi. We do have some questions, but this would be a good time just to type them in, and we'll ask our panel the questions, and then any questions that we're not able to answer today, we'll forward on to our expert presenters for individual follow-up. All right. Let's see. First question is, how long does it take to create the initial test, including whole exome sequencing?
So I can take that one. So as you know, there's basically two parts to this test. The initial Signatera assay needs to be designed with both a sample of the tumor tissue and a blood sample, one for whole exome sequencing of the tumor and the other one for whole exome sequencing of germline. And that can take 3 weeks to get that first baseline result. But subsequently now, once those genes that or single nucleotide variants that are going to be monitored longitudinally, all it takes is a week to get results for subsequent Signatera test results. So as fast as we can get the tissue, the quicker we can get those results for decision making.
Okay, thank you. I think this is for you as well, Dr. Rodriguez. Does the Signatera report also include actionable mutations?
So great question. As you know, as I mentioned, the main purpose of the Signatera assay is to act as a tumor marker of sorts. A tumor marker where no patient gets left behind with accurate assessment of their disease, molecularly speaking. We do not report actionable mutations, nor do we report the tumor suppressor mutations or KRAS, for example, mutations. We just basically report results of those truncal single nucleotide variants that exist within the patient's tumor.
Okay, next question, two-part question. What are other recommended tumor types for this test? And do you recommend using for hematologic malignancies?
I'll first answer the second one in terms of hematological malignancies. This test is not designed to be used with leukemias, right? Actually, we already have other tests that are used for disease monitoring in those settings. There is research currently being conducted in the area of non-Hodgkin's lymphoma and multiple myeloma. But for the meantime, this test is not recommended in those settings just yet. And then as far as other recommended tumors, this is tumor agnostic in that a Signatera assay can be designed for any solid tumor. Now we do have a pending Medicare draft coverage, which is pending, but that is specific to stage 2 and stage 3 colorectal cancer and oligometastatic disease.
Okay, thank you. I believe the next question is for Dr. Azzi. How did you counsel your patients regarding Signatera positive versus negative results?
Yeah, so obviously a positive result means a higher risk of recurrence, as we've seen with validation data. So therefore, these patients, have a high risk of recurrence. They're going to benefit the most out of chemo because that's the best we can provide, adjuvant chemotherapy. So they should definitely get it. If there's any, concern or like they really want to avoid the chemo, I would highly discourage that because they will benefit from chemotherapy. Unfortunately, though, for the patients that are negative, even with our best adjuvant therapy, they still have a high risk of relapse and should be followed very closely. For the ones that are negative, we know that risk is lower, but one time point, again, is by itself significant, but it's better to have a serial time points, and if you remain negative throughout that first year and even the second year after your adjuvant therapy, we now know that risk, eventually falls to below like 3% of risk of recurrence. So therefore, they do have a lower risk of recurrence, and eventually we can relax that imaging regimen and feel comfortable that, there will be no surprises.
Okay, thank you. Next question. Do you have data to show that patients with oligometastatic CRC with clinical complete response can stop treatment if they are ctDNA negative?
So good question. I think there's a lot of controversy and clinical challenges when it comes to patients with oligometastatic disease. So just this year in ASCO, in virtual ASCO 2020, JCOG presented data showing that adjuvant chemotherapy can improve disease-free survival in these patients, but it paradoxically worsened overall survival. We do expect to present data this year in ESMO in regards to the effect of adjuvant chemotherapy in patients with oligometastatic disease. But at this point, certainly what we can say is that the risk, the prognosis will be better in patients who test ctDNA negative and who test ctDNA negative serially, as opposed to patients who do test positive. So it is a tool that can be considered when making treatment decisions in regards to continuing chemotherapy, especially in the setting of having adverse side effects. But maybe Dr. Azzi, you could elaborate in that on that scenario. How would you treat a patient with oligometastatic differently if they had ctDNA negative versus positive?
Yeah, I mean, obviously, oligometastatic, I mean, if they're positive, and if it's limited disease, we're still going to try to treat it either with radiation and or resection, and then possibly continue with some chemotherapy. But I feel more comfortable eventually, discontinuing that chemotherapy if they are negative, and trying to have a treatment holiday basically while being monitored with the cell-free DNA. And if that treatment holiday remains in like cell-free DNA negative, then we could basically extend it. If unfortunately they do go back to positive, they go back on the more frequent imaging, and then potentially also consider chemo since they are a stage 4, and if they become positive again, obviously that is, again, a metastatic realm, and they might benefit from chemotherapy. So it's more of a personalized discussion with each patient.
Okay, thank you both for that. Question for Dr. Azzi. Have your patients expressed anxiety about receiving a positive result after receiving a series of negative results?
Yes, I mean, obviously anxiety, and we know it in the oncology realm. There's scan anxiety, there's tumor marker anxiety. It is, something that we have to deal with, us and the patient on a routine basis. And it depends. Some patients will opt out, obviously, of not wanting to participate in MRD program because they have a high level of anxiety and they don't want to deal with the possibility of like identifying something positive that they might not be able to immediately act upon. But most patients actually do want to know the maximum amount of information they could gather, and they want to personalize their follow-up. And for most patients, that negative results, mean a lot to them. If eventually it becomes positive, we'll have to counsel them, and I would have counseled them up front about the possibility of getting a positive, and then how we will basically customize their imaging program to detect this early and possibly improve their outcomes. And, because sometimes these positives might come where you had already been planning to go on the yearly imaging, and where with the Signatera you can repeat that maybe every 3 months, and then if a positive happens, you're not going to be waiting another year to basically detect a relapse. You'll be able to intervene within the month after you get the positive and potentially detect a resectable lesion before it grows.
Yeah, great. I think Dr. Rodriguez has a follow-up question or additional question there.
Yeah, Dr. Azzi, I'd like to ask you a question. Of course, there's things we know, about this, the MRD and ctDNA in colorectal cancer, such as, that extremely elevated risk of recurrence when it's ctDNA positive. But can you comment on the difference of the two cases that you presented and how they differed in terms of the clearance of their ctDNA, where one just rapidly became negative, after treatment, whereas the other one kind of took a little longer? I mean, just in terms of what you think that may mean.
Yeah. Obviously, I mean, we need a lot more data on this, but obviously, the faster we know, the faster you clear the DNA, the deepest that or steepest the curve is on that DNA clearance, obviously the better the outcomes. I mean, we know that from oncology, from lung cancer, EGFR data with ctDNA clearance. So obviously, the faster you clear it, the better it is. The more sensitive your disease is, and probably the most curable it is in an adjuvant setting. In the first case, that clearance came pretty quickly, as you said. In the second one, it makes me concerned that obviously what we're dealing with here is a metastatic setting that might unfortunately be not curable, and therefore we would have to monitor closely. At this point, I cannot prove it on imaging, so I would still stop at the 6-month mark of the therapy, but monitor closely with the ctDNA for any recurrence, and then customize the imaging plan, hopefully trying to detect something that could be possibly oligometastatic. If not, then once the patient develops metastatic disease again, we will proceed with treatment. Ideally, we should have some trials coming through for treating patients that have a recurrence of their cell-free DNA post initial adjuvant therapy. Right now, we still don't have any of those trials. I think the Bespoke trial might be collecting some of that data if the investigator decides to put them on another type of chemo, but obviously that's not a randomized trial. But I think this is a very needed arena right now to try to develop therapies that are in the post-adjuvant setting, basically like we see in breast now, where patients get in the HER2 setting, where they try to treat them for the ones that don't get a complete response. And here we have obviously a perfect marker of patients that are not getting complete responses after their adjuvant therapy and are still at high risk of relapse. And this is obviously going to be an arena for development of a lot of therapies, I hope.
Yeah, I'll just mention that we have already enrolled our first patients in the Circulate trial, which is being run by JCOG, which is precisely that. It's testing on MRD positivity or recurrence after best standard of care adjuvant treatment with either FOLFOX or CAPOX. And so we obviously eagerly await the results of that study to see if treating on ctDNA, on MRD, might give our patients a second chance of cure.
Okay, with that, one last question here. How can I order Signatera? Is it available outside the U.S.?
It is available outside the U.S. We have different sort of, depending on where it is being ordered, you can either, contact us through email or phone, and we can direct you to the right person.
Okay, great. On behalf of the audience, I want to thank Dr. Rodriguez and Dr. Azzi for their great presentations and handling the questions here. Thank you very much.
Great. Thank you, Bob. Thank you, Dr. Azzi.
Thank you. Thank you all.
Okay. At this time, we will end the webinar, and you may now disconnect. Thank you very much, everyone.